Usually when we talk about a medical diagnosis, there's um, this expectation of precision.
Mm.
Like it feels engineered, right?
Right, yeah, like it's entirely binary. Broken or not broken.
Exactly. You break your arm, the x-ray shows that like jagged white line, and the doctor just points and says, well, there it is.
Yeah, we inherently prefer conditions that are visible and, easily categorized, mostly because they offer a clear, immediate action plan.
Right, but then you step into the world of mental health, and suddenly that x-ray machine is just utterly useless.
Utterly useless, yeah.
The diagnostic landscape becomes incredibly murky. We're looking at a space where the public perception of a condition is often wildly disconnected from what an individual is actually experiencing day to day.
I mean, and nowhere is that disconnect more profound than with borderline personality disorder, or BPD.
Yeah.
It affects roughly 1.4% of adults in the U.S.
Which is a huge number.
Yeah, it is. When you look at the total population, we are talking about millions of people navigating a deeply complex condition. Yet, it carries one of the heaviest, most pessimistic stigmas in the entire medical field.
Okay, let's unpack this, because we are going to get into how modern care models, specifically telehealth, are changing the landscape for this diagnosis.
Right.
But to understand why these new care models even matter, we first got to understand what BPD actually does to a person.
Absolutely. You have to start with the symptoms.
Right. And looking at the clinical features from our source material today, and we should remind everyone listening, a diagnosis strictly requires a licensed clinician. No self-diagnosing allowed here, but the symptoms are just incredibly intense.
They really are.
We're talking about severe fear of abandonment, unstable relationships, identity disturbance, impulsivity, emotional dysregulation, chronic emptiness, and just profound difficulty managing anger.
Yeah, and it really helps to separate those symptoms into two distinct buckets to truly grasp the mechanics of what the individual is enduring.
2 buckets.
Yeah, so in the first bucket, you have the relational hurdles.
Okay.
The intense fear of abandonment and the unstable relationships. These dictate how a person interacts with the external world.
So it's all about how they connect or fail to connect with others.
Exactly. There is a constant, terrifying anticipation of being left behind. And the cruel irony is that this intense fear can drive a person to act in ways that inadvertently push people away.
Creating the exact relationship instability they were terrified of in the first place.
Precisely. It's a self-fulfilling prophecy in the worst way.
Man, that sounds like an exhausting cycle of panic.
Yeah.
But what about the other bucket? Like the other symptoms you mentioned, identity disturbance and chronic emptiness.
Right, the internal struggles.
Yeah, I'm having a hard time visualizing how those fit in, because if someone is highly reactive and impulsive, doesn't that imply they're constantly, doing things?
That's what people assume, yeah.
So how does someone experience maximum impulsivity and chronic emptiness at the exact same time?
What's fascinating here is that this internal contradiction is the private pain the outside world rarely understands.
Okay.
Think of identity disturbance as a profound, agonizing uncertainty about who you are at your core.
Like your values.
Your values, your goals, your literal place in the world. And the chronic emptiness isn't just feeling, a little sad on a Sunday afternoon. It is a persistent, painful, physical void.
Oh, wow. So it's visceral.
Very much so.
So how do those 2 buckets interact then? You have someone terrified of being abandoned while simultaneously feeling completely hollow inside.
Well, imagine sitting in the driver's seat of a car where the mechanics are fundamentally altered.
Okay, I'm tracking.
The gas pedal is so dangerously sensitive that the slightest tap makes the engine roar to maximum RPMs.
Like 0 to 60 in a second.
Exactly. That is emotional dysregulation. Every single feeling, joy, anger, sadness, hits with overwhelming velocity.
Okay.
But at the exact same time, your GPS is completely blank. You have absolutely no internal direction, no destination.
Ah, I see.
That is the identity disturbance and chronic emptiness.
Okay, so maximum emotional velocity with 0 internal direction. I mean, if I'm driving a car like that, erratic driving isn't just a possibility, it's practically guaranteed.
And that erratic driving translates to the behavioral impulsivity and anger that the outside world is so quick to judge.
Right.
The impulsivity isn't just a person being reckless for the fun of it. It is very often a desperate, high-speed attempt to either fill that agonizing internal void or an attempt to somehow hit the brakes on an emotional system that is totally dysregulated.
Wow. If a person's internal engine is running that hot and that erratically, it seems highly unlikely they would only experience one isolated set of problems.
Yeah.
Like driving a car like that means you're going to hit multiple obstacles.
Which is exactly why BPD rarely exists in a vacuum. It sits at the center of a very complex co-occurrence web.
So it brings other conditions along for the ride.
Frequently, it often presents alongside severe anxiety disorders, mood disorders like major depression, and substance use disorders.
The anxiety makes a lot of sense. If you are constantly terrified your partner or your friends are going to abandon you, clinical anxiety is an almost guaranteed byproduct.
Absolutely.
But where does the substance use fit into that specific web?
Substance use in this context is frequently an attempt at manual calibration.
Manual calibration, like self-medicating.
Yes. If a person lacks the internal psychological tools to manage that hypersensitive emotional gas pedal we talked about, they will look for external tools to numb it.
Oh, I see.
It is a tragically logical attempt to self-medicate the dysregulation.
Okay, so this paints a really heavy picture.
Mm.
We have a deeply painful internal experience that produces behaviors the outside world heavily stigmatizes, leading to a tangled web of anxiety, depression, and substance use.
It is heavy.
But the data from the source shows us a totally different trajectory is possible, right?
Yes, very much so.
Like the evidence-based treatment for this is Dialectical Behavior Therapy, or DBT. And the outcomes are genuinely strong.
They absolutely are.
People who receive coordinated DBT-informed care can and do build stable, highly meaningful lives.
They do, because DBT is a structured approach that specifically targets the deficits we just talked about.
It gives them the steering wheel back.
Exactly. It teaches tangible skills for emotional regulation, distress tolerance, and interpersonal effectiveness.
Wait, let me stop you there for a second, because distress tolerance sounds a bit like clinical jargon.
Fair enough?
What does that actually mean in practice? Are you just telling someone to grit their teeth and bear it?
Not at all. Distress tolerance is about learning how to survive an emotional crisis without making the situation worse.
Okay.
Let's go back to our car analogy. If that hypersensitive gas pedal gets slammed down, say, the person feels an overwhelming wave of anger or fear, their instinct is to act impulsively.
Because they're in pain.
Right. Distress tolerance teaches them physical and psychological techniques to endure that spike in emotion until it naturally peaks and begins to subside.
Interesting. Like what kind of techniques?
Well, it might involve physiological tricks, like holding a piece of ice to shock the nervous system and force a physical reset, rather than lashing out at a loved one or turning to a substance.
Seriously, just holding an ice cube.
Yeah, the temperature shift forces the brain to focus on the physical sensation, lowering the emotional temperature.
So you are literally teaching the nervous system how to ride out the wave instead of drowning in it.
Yes. And that is where the dialectical part comes in.
Right. Dialectical behavior therapy. What does that actually mean?
A dialectic is the synthesis of two seemingly opposing truths. In DBT, the core dialectic is acceptance and change.
Acceptance and change.
Yeah. The therapist works to help the patient radically accept themselves exactly as they are in this current moment.
Validating their immense pain.
Exactly. Validating that pain while simultaneously holding the absolute truth that the patient must change their behaviors to build a life they actually want to live.
Man, accepting who you are while demanding you change how you act, that is a fascinating tightrope to walk.
It is the hardest work a person can do.
But here's the thing I keep getting stuck on. And maybe you can clear this up.
Sure.
If DBT works this well, if it can literally recalibrate someone's nervous system and help them manage these intense symptoms, why is BPD still viewed as this massive, terrifying red flag in the culture?
It's a great question.
If we have the tools, why does the stigma persist so heavily?
That persistence of stigma is frankly a systemic failure of the medical establishment.
Really?
Yeah, you have to look at the history. Before therapies like DBT were developed and refined in the late 80s and 90s, clinicians simply did not know how to treat BPD.
So they were just winging it.
Sort of. You had patients showing up in emergency rooms or clinics in profound emotional distress, sometimes engaging in self-harm, and the doctors and psychiatrists lacked the specific tools to help them.
And, well, when professionals feel helpless, they tend to get defensive.
Precisely. Medical helplessness often mutates into frustration.
Hmm.
Instead of the system admitting it lacked the necessary treatments, the patients were frequently labeled as untreatable, difficult, or attention-seeking.
Blaming the patient for the doctor's lack of tools.
Exactly. That systemic burnout created a pervasive culture of pessimism around the diagnosis. Even though the clinical reality today is completely different, that historical bias leaked into the broader culture, and it remains incredibly sticky.
That is wildly unfair. that a patient today has to carry the baggage of a medical system's past failures.
It is.
But it highlights a massive structural problem today, because knowing that DBT works is a huge relief. It's incredibly hopeful,
Yes.
but doesn't mean anything if a person can't actually find a clinician trained to provide it. The treatment is useless if it's locked behind a wall of logistical barriers.
Access to specialized care is the defining crisis of modern mental health.
Right.
It's one thing to say a person needs DBT-informed therapy. It's another entirely to locate a licensed professional within driving distance who has openings.
Which is exactly why the care model we are looking at today is so vital.
Yeah, coping and healing counseling.
Right. We're examining how this specific telehealth practice, coping and healing counseling, or CHC, is actively dismantling those exact logistical walls.
They really are.
They operate across the entire state of Georgia, all 159 counties, and they've built a diverse team of over 15 licensed therapists, social workers, professional counselors, marriage and family therapists, specifically providing DBT-informed telehealth.
If we connect this to the bigger picture, the structure of their practice is a direct response to the specific hurdles of treating complex conditions. Notice that they explicitly emphasize having a diverse, culturally competent team. That is not just corporate messaging, it is a clinical imperative.
I want to push on that for a second, actually.
Go ahead.
Because if DBT is a structured therapy, like if it involves specific skills like holding ice or learning distress tolerance from a manual, why does the cultural background of the therapist matter so much? Isn't the manual just the manual?
That's a common misconception.
Yeah.
Because therapy is never just reading from a manual. Think back to the core symptom of identity disturbance. You are asking a patient to come into a virtual room and expose their deepest insecurities, their erratic behaviors, and their profound feelings of emptiness.
Right. It's incredibly vulnerable.
That requires immense foundational trust. If a therapist lacks cultural competence, if they cannot understand how a patient's race, background, or community norms intersect with their mental health, they risk invalidating the patient's lived experience.
Oh, wow. And invalidation is exactly what someone with BPD is already hypersensitive to.
Exactly. If a patient feels misunderstood on a fundamental cultural level, the therapeutic alliance shatters before the DBT skills can even be introduced.
The therapy ends before it even starts.
Right. So a diverse team ensures that patients can find a clinical match who truly sees them, which is the necessary bedrock for doing the hard work of behavioral change.
That makes a lot of sense. And it makes the scope of their practice even more impressive to me. Because they aren't just treating BPD.
No, they handle a wide range.
Yeah, the source notes they handle anxiety, depression, trauma, PTSD, grief, severe stress. And they offer individual therapy, couples therapy, family therapy, and crucially, teen therapy starting at age 13.
And that age piece is critical. Integrating teen therapy alongside family and couples counseling is a deeply strategic approach to treating emotional dysregulation.
Because it's not just an isolated issue.
Right. Conditions like BPD do not just impact the individual. The blast radius affects the entire family system.
Yeah.
When a teenager is operating with a hypersensitive emotional gas pedal, the parents and siblings are often caught in the crossfire.
Leading to a highly reactive, stressful home environment.
Exactly. So treating just the teenager in isolation isn't enough. You have to teach the family how to stop throwing fuel on the fire.
By offering family sessions and teen therapy starting at 13, a practice can create this, holistic safety net.
It's vital. Intervening at 13 with dialectical skills means you are handing a young person the steering wheel before they start driving at high speeds. It quite literally alters the trajectory of their entire adult life.
Man, the logistics of delivering that care across an entire state are fascinating to me, too. Because Georgia has a massive geographic footprint.
It does.
You have incredibly dense urban centers like Atlanta, where the barrier to care might be, endless wait lists.
Right, or terrible traffic.
Exactly, but then you have vast rural counties where a specialized DBT therapist simply does not exist within a 2-hour radius. By functioning as a 100% telehealth practice, CHC is entirely eliminating that geographic barrier. It's like a highly specialized rapid response team that can instantly beam into any living room in the state.
And we cannot overstate how important that is for a patient with severe anxiety or emotional instability.
Why is that?
For many people, the sheer logistics of traditional therapy, navigating traffic, finding parking, sitting in a crowded, sterile waiting room can trigger so much anxiety that they are completely dysregulated before the session even begins.
Oh, I hadn't even thought of that. The commute itself is a trigger.
Telehealth allows the patient to engage in the most vulnerable, difficult, emotional work in the absolute safety of their own environment.
But, geographic access is only part of the equation.
Sure.
You can be in the best therapist in the world into someone's living room, but if that person can't afford the session, the laptop stays closed.
The financial barrier is the ultimate gatekeeper in the American healthcare system.
Without a doubt. Specialized therapy, especially evidence-based treatments like DBT, is notoriously expensive and frequently out of network.
The financial infrastructure of mental health care often actively works against clinical outcomes.
Which is exactly why the financial logistics of CHC stopped me in my tracks when I was reading the source.
It is unique.
They're entirely hypocope-aligned, so the privacy is locked down, but it's their insurance model that breaks the mold.
Right.
They accept major commercial networks like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, Humana, but they also accept Medicaid.
And that's huge.
And for a Medicaid patient, there's a $0 copay. Zero. I mean, finding a specialized therapist that takes Medicaid is like finding a unicorn. But a $0 copay,
It's almost unheard of.
even for patients using other accepted insurances, the sessions generally range from $10 to $40.
This raises an important question, though, about the actual clinical value of that pricing. To understand the impact, you have to look at what financial anxiety does to the human brain.
It puts you in survival mode, doesn't it?
It creates a state of chronic physiological stress.
Okay.
Imagine a patient trying to learn complex emotional regulation skills. They are trying to engage their prefrontal cortex, the logical reasoning part of the brain, to learn how to synthesize acceptance and change.
Which is already incredibly hard.
But at the exact same time, they are experiencing intense anxiety about how they are going to pay a $200 out-of-pocket fee for the session they are currently sitting in.
Oh, man. So their amygdala is just firing constantly. They're just trying to survive the financial hit.
And when the amygdala is hijacked by stress, the prefrontal cortex cannot optimally learn new skills.
The therapy is essentially fighting against the patient's own survival instincts.
Exactly. By structuring a practice to accept Medicaid for a $0 copay and drastically lowering the out-of-pocket costs for others, the clinic is actively removing that financial stressor from the room.
It frees up the cognitive bandwidth so the patient can actually do the work.
It aligns the economic reality of the patient with the clinical goals of the treatment.
This is brilliant.
The patient doesn't have to worry about affording the help. They only have to focus on the profoundly difficult work of healing.
It is incredibly cohesive. When you look at the entire model, it feels like they systematically identified every single reason a person might abandon treatment.
They really did.
Geographic isolation, solved by telehealth. Financial impossibility, solved by accepting Medicaid and lowering copays. Cultural mismatch, solved by hiring a diverse, competent team. Systemic stigma, solved by relying on evidence-based, DBT-informed care.
Yeah.
They just systematically neutralized every excuse the system historically provided.
It is a remarkable synthesis of clinical expertise and accessible infrastructure.
We have covered some seriously profound ground in this deep dive.
We really have.
Let's trace the path we just walked. We started by looking straight at the heavy stigma and the intensely painful reality of borderline personality disorder.
The two buckets.
Right. We explored the mechanics of the condition, that internal contradiction of massive emotional velocity paired with a blank internal destination.
The hypersensitive gas pedal.
Exactly.
Yeah.
We didn't stop at the pain. We looked at the proven mechanics of dialectical behavior therapy. We saw how learning distress tolerance and balancing radical acceptance with behavioral change can completely alter a person's life trajectory.
And we connected those clinical concepts to the practical reality of how care is actually delivered.
Right. We saw how care models like coping and healing counseling are utilizing telehealth, diverse staffing, and accessible financial structures to ensure that these life-saving tools aren't just, theoretical concepts in a medical journal.
They're accessible.
They're actual lifelines available across all 159 counties of a state.
And for you, listening to this right now, it is vital to remember the underlying purpose of unpacking these details.
Why does it matter to them?
You might be exploring this because you recognize some of these intense emotional struggles in yourself. You might be trying to understand the erratic behaviors of a family member or a partner, or you might just be someone who wants to understand the world a little better.
Yeah.
Regardless of your reason, the societal stigma surrounding mental health diagnoses only begins to crumble when we replace our assumptions with actual understanding.
Completely agree.
It starts when we understand the sheer weight of what people are carrying and the concrete realities of how treatment actually works.
It's about dismantling fear through genuine comprehension.
Exactly. And I want to leave you with one final thought to mull over.
Okay.
Throughout this deep dive, we have discussed how specialized tools, specifically the dialectical skills of balancing self-acceptance with the rigorous demand for behavioral change, can completely alter the life trajectory of someone navigating a highly stigmatized, severe personality disorder.
Right. It saves relationships. It saves lives.
We know these tools help people endure massive emotional dysregulation without destroying their relationships. But consider this.
Yeah.
If these specific tools are that profoundly effective for the absolute extreme edges of human emotional suffering, what could those exact same dialectical tools do for you?
Oh, wow.
How might your life change if you applied that same distress tolerance and radical acceptance to the everyday anxieties, the interpersonal conflicts, and the routine emotional hurdles of your own modern life?
The very tools designed for extreme healing are often the exact blueprints for everyday thriving.
They are.
It fundamentally shifts how you view the landscape of mental health. It's not just about categorizing what is broken and isolating it. It is about wading into those murky waters, understanding the mechanics of our own minds, and ultimately learning how to steer. Thank you so much for taking this deep dive with us today. We will catch you on the next one.